we're going to talk about GERD, G-E-R-D, gastric esophageal reflux disease. And what that is pressure in the stomach, and ends up pushing the acid up into the esophagus. The esophagus doesn't have that nice protective lining that the stomach has, so it burns. It damages cells in the esophagus. You can end up with Barrett's esophagus, which is thickening of the lining there, where you get overproduction of cells. You know, kind of like I always think of it like if I'm overusing my hands, I get calluses on my hands, overproduction of skin. I don't know if that's a good analogy or not, but it helps me remember that that's what Barrett's esophagus is, and it's a response to having gastric esophageal reflux disease for a long period of time. Now, what do we do for that? Now, for one thing, you've got a lot of acid getting pushed up in there. So there's a couple things that can cause it. One is a malfunction in the sphincter that happens here, the lower esophageal sphincter, which we call the LES, lower esophageal sphincter, less, right? So you get, if that thing is malfunctioning, it doesn't keep the acid down, and the acid can splash up in there. Also, just hyperacidity. Hyperacidity completely alone in a great functioning LES, you're probably not going to get a real big problem with that. More likely that you might have a problem with peptic ulcer disease, but you might, right? If you have both, if you have hyperacidity and an LES, it's not functioning correctly, or not functioning well, you're really going to get it bad. So let's talk about some of the reasons that you might get it. The number one reason, obesity. Right? That's the number one reason. Probably because we have so many obese people, that's the number one reason. But you've got a stomach here. If you look at my upper stomach here, and this is how the stomach would be. You've got your esophagus coming down, kind of comes in a little angle, and then you've got your stomach here. You've got this acute angle here that it creates, right? Acute meaning sharp angle. And when food comes in here and the stomach starts churning, it pushes that up and closes that sphincter, right? So by pushing up on that sphincter, it stops reflux from happening. Well, that's great as long as you're like this, but when you get obese, what happens is the stomach gets kind of pushed up, right? You get this fat kind of pushing up under here, and the stomach gets pushed up. Instead of being down like that, the stomach gets pushed up. And getting pushed up, it drops the other portion of the stomach, and now you don't have that nice sharp angle that's going to push up. Now when the stomach starts churning, it pushes this acid right up into the esophagus. So you can kind of see just by this drawing kind of how obesity is a big problem with pushing this acid up in there. Not only do you have pressure from down below pushing up, you've also deformed the stomach in a way that it has made the LES inefficient. Now, another reason for you can have, there are people that are just born with an LES that doesn't function well, right? And so right there, they just have a genetic predisposition to having this problem. Overeating. Overeating is another big problem. If you eat a lot when you eat, and I know a guy who's in great shape, but when he eats, he'll eat like a whole large pizza. But he also works out a lot. I mean, he likes to compete in these things that they have in Chicago, these competitions, you know, where they jump over trucks and cars and underneath things and over these obstacle course type things. And I mean, he places pretty high in these, so you know, he's in great shape. But when he eats a lot. Stretches that stomach out every time he eats. And then he might only eat once a day. When he eats all this food, stretches this muscle out, right? So by stretching this muscle out, it thins the muscle, and it makes it so that muscle isn't as efficient at emptying the stomach. And it also thins this and makes it so the LES is not as efficient or as strong as what it should be. So you end up with delayed gastric emptying and an inefficient LES, which is going to keep the food, delayed gastric emptying, it's going to keep the food in here longer, and it's very full, and this guy here can't hold it back, so you end up with gastric reflux. These are the guys that really just need to learn to eat 3 or 4 meals a day, right? Small meals rather than one big large meal. And when you overfill the stomach like this, if you really overfill it with a lot of fatty foods tend to want to sit in the stomach for a longer period of time. So you got the delayed gastric emptying, so it's sitting there for a longer period of time. So you really want to avoid those fatty foods, like if you're drinking a glass of milk with your meal, make it non-fat milk, right? You don't, rather than the whole milk or the 2%, maybe even something like if you can get used to drinking almond milk or something like that. Another reason for delayed gastric emptying can be diabetic gastroparesis. Diabetes is hard on your nerves, right? You end up with peripheral neuropathy, and when you end up with peripheral neuropathy, we know that you get numbness and tingling down in your feet and your hands, and you can get pain in your there, but it can also affect the nerves that are bringing the messages to the stomach, right, that I was talking about, the vagus nerve. So if it affects that, it's not going to have the motility that it needs to churn this food and to move it forward. In fact, they give metoclopramide, Reglan, for that, because Reglan tends to stiffen up the LES, right? Increases the function of the LES, makes the stomach more active, and it relaxes the sphincter down in here. So it's going to move food through. So it's going to promote movement of the food through, right? The food that comes down and then the chyme on through to the duodenum. And some things that increase acidity is NSAIDs, we've talked about that, smoking, spicy foods, and alcohol. And alcohol also can decrease the effectiveness of the LES. So alcohol is one of the things that can lead to a problem here. Okay, so now I want to talk about some of the treatments for GERD. Number 1, weight loss. Stop smoking. Avoid spicy foods. This thing is not working so well. Let's switch to this one. Avoid citrus juices. Right? Orange juice, all that stuff, all this acidic juices, you want to avoid those. Avoid alcohol. And avoid any fizzy drinks, right? All these carbonated beverages, no. Decrease fatty food intake. Better off to have frequent, small meals rather than few large meals. No eating two hours before HS. So before your bedtime, no eating before you're going to go to bed. And because that's when GERD really hits people, when they lay down, right? You might get it during the day, and sometimes when you bend over, you're bending, and you push that acid up into the esophagus. But when you lay down, boom. If you have a GERD problem, you want to go to bed with an empty stomach, right? You don't want food in your gut, because if there's anything in there, if it's working on anything, that chyme is just going to come right up into your esophagus. So that's some of the teaching that you're going to do for somebody who has GERD. I'm going to erase this again. We'll talk about some of the meds that we can use for this. We can take some antacids, right? They can neutralize the acid in the stomach, decrease the acidity, right? But like I said, there's going to be a rebound from that. We can take H2 blockers. We can take proton pump inhibitors. Now the thing about these are they might make you feel a little bit better, but you still get that reflux. And you still have the enzymes in there that can be hard on proteins and stuff, so they can still really irritate the lower esophagus, and by doing so you can still end up with Barrett's esophagus. You can still end up with the follow-up of Barrett's, so you get Barrett's, and then after that a lot of times you can move into cancer of the esophagus, right? So those are things that that's a progression that you're not really slowing down much, if at all, by taking antacids, H2 blockers, and PPIs. All they're doing really is just making you a little bit more comfortable. The big thing really is those things that I told you before. And another thing is very often they'll tell you to raise the head of your bed a little bit. You can put blocks under the head of your bed. I don't know how many people actually do that, but it's one of the things that they suggest. They might give some metoclopramide because, like I said, metoclopramide can increase the LES function. So metoclopramide can increase the LES function, right? And it can move food through. So it can get rid of some of those things that cause the problems. And then there's a thing, a Nissen's surgery. N-I-S-S-E-N-S. And what that is they take a portion of this, of the stomach here, and wrap it around here. Let's use this one down here. They take it and they'll wrap it around here. So I'm going to grab some brown here. And this guy here can be kind of brought up around like this. And it's going to come around here. Get rid of them words there, kind of get in the way. Alright, so you got your esophagus coming up like this. This guy here has been wrapped around the back side of that. Comes around here. It's wrapped around there, right? And what it does, now you've got this wrapped around here, so it stops things from being able to come up through there. That's pretty nice. Most people, well, I've only known a couple of people actually that have had this surgery done, but they said, wow, yeah, it really gets rid of the esophageal reflux. And I worked as an emergency room nurse for 25 years, and when I saw these people, they were in the emergency room because they needed to puke and they couldn't vomit, right? They can't vomit because they've got this wrapped around here, and it kind of stops the vomiting, and they are miserable. Put an NG down and kind of get some of that stuff out of there. Give them medicines to try to stop the nausea. But anyway, that's what the Nissen's surgery is. That's how they handle that. So now, I want to talk about one other thing that I kind of forgot to mention before, and that is hiatal hernias, right? Big time with GERD, hiatal hernias. Now, right there with the LES, you've got the diaphragm right above the stomach, right? The stomach's right up tight against the diaphragm. Probably should have made it down here. All right, because it's right there. Now, the hiatus, right here, the hole here that the esophagus goes up through, if that thing gets stretched out, what can happen here, and you got to remember, in the chest, the thoracic cavity, you have a negative pressure. So it's really, every time you, especially when you take a breath in, it's going to pull that up through there. So what happens here is this guy here comes like this. And it bulges out. Right, this little portion of stomach comes up through the diaphragm and bulges out like that, right? So now you've got this bulge here up in there. What do you think's going to happen there? Well, that ain't going to empty, right? So now you've got all the acid and stuff, and it could just come right, splash right up in here, and it's just going to get up into the esophagus and irritate the esophagus. And that's called a hiatal hernia. Right, so you got a hiatal hernia, can cause that kind of a problem. And that can be repaired. Hiatal hernia can be repaired. They can pull it down there and try to repair it. It's a small one, they don't want to bother with it, right? They'll just try to tell you to sit upright and don't go to bed with, with a full stomach, stuff like that. Okay, so I'd say that I'm done here talking about peptic ulcer disease and Gerd, right? Hopefully it kind of helps you understand what the process is, or what the problems are, and what some of the medicines are, and why we use different medicines, and why we gives different teaching to patients with those problems.